Welcome to Speech Scope, a MedBridge podcast where we conquer challenging topics for the medical SLP. Our aim is to deliver actionable takeaways for clinicians like you through captivating discussions with experts in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, Sarah Baar, a clinical SLP in Michigan with over 15 years of experience. I specialize in adult neurogenic disorders and the life participation approach. Today, I'm excited to be joined by Brooke Richardson, medical SLP and an expert in the area of respiratory muscle training. We'll be diving deeper into this topic, including recent research and actionable takeaways you can implement right away. So glad you're here, Brooke. Could you get us started by sharing a little bit more about yourself?
Absolutely. And thank you so much for having me today. I am thrilled to be meeting with you and guesting on this podcast. I'm a medical speech pathologist based in the United States. I've been taking care of medically complex adults from ICU to outpatient settings since 2009, and I've been incorporating respiratory muscle training, or RMT as I'll call it, into my practice since probably about 2012 or so. And sometime around 2016, I caught the teaching bug and became an accidental entrepreneur and teacher sometime shortly after that. And thanks to the teaching bug, I am now the owner and founder of the Modern Med SLP, which is a continuing education platform for SLPs, and Breathehab, which is a continuing education platform specific to RMT for all disciplines.
Fantastic. It's always exciting to hear about clinical SLPs who've, not only taken an interest or a passion with a really specific topic like respiratory muscle training, but you've really gone a step beyond that. You're a leading voice for SLPs on this topic. You're coming up with new ideas to support using RMT in clinical practice. I'd love to just hear a little bit more about your journey, how you initially became so interested in RMT and how your passion evolved over time.
Sure. I started using RMT at a hospital where it was already an established program. So I got trained in it and was really, really lucky to learn from some really bright fellow clinicians. And the more that I used it, I found it to be a really interesting tool in the clinical toolbox. And also as I continued to use RMT in practice, I started to have a lot more questions and curiosities about the therapy and went down a very deep rabbit hole reading the literature. I just wanted to know more about why this and why not that. And the more questions I asked, the more questions I continued to ask. Every question gave me an answer, but probably gave me about 100 more questions that I wanted to ask. And just as a curious clinician myself, I have continued to learn over the years. And interestingly, in the hospitals that I've worked at, RMT has been considered an SLP modality. And I think that's really just from organizational cultures. Like this hospital had the program set up by speech pathologists, and that's just who kind of owned the program or who was responsible for the program. And the only department or specialty that provided respiratory muscle training. And another hospital intentionally set it up that way. So it's very interesting to see how it can be considered an SLP modality. But the more that I've learned about it and have had more opportunities to collaborate with other disciplines in patient care in general, I've really come quickly to realize just how important it is to provide interdisciplinary patient care and education in RMT, as well as other aspects of what we do. So really, really long and wonderful rabbit hole that I have gone down over the years.
Fantastic. I find it really interesting, first of all, that the hospitals you've been at have had this primarily as an SLP modality, only because that hasn't been my same experience in the hospitals I've worked at here. So I know respiratory muscle training is relatively new as an aspect of our clinical practice when we're talking about the world of medical speech pathology and, depending on our hospital policies, for some of us newer than others. I thought we would just start our chat today getting everyone on the same page of the basics. So we're going to save our breath a little bit and just call it RMT. So what is RMT? Why does it matter? Why do we care about this in the world of, speech pathology or other disciplines? And then what does this just involve at kind of the basic level?
Sure. So RMT, as you might guess by the name, strengthens the respiratory muscles. But I do want to take a quick moment here and reiterate that it doesn't strengthen the lungs. Sometimes I hear people say, oh, this is a therapy that strengthens the lungs or helps with other things that may not necessarily be the case. So respiratory muscle training, as silly as that might sound for me to repeat, is training the respiratory muscles themselves. And clinicians, we're going to ask our patients to use devices. Typically, these are going to be pressure threshold devices, but there are other kinds of devices on the market. And these devices provide load to the respiratory muscles, inspiratory or expiratory. And these devices are akin to using weights at the gym. So if I go to the gym and I want to lift weights, I'm going to put a pin in that machine. I'm going to know exactly how much weight I'm lifting. Respiratory muscle training is a similar concept, again, specific to the respiratory muscles. So these devices, these pressure threshold devices, are lightweight and they're pretty low cost and highly portable, which makes it very nice for patient care no matter what setting we're working in. And as I mentioned a minute ago, there are other methods of RMT, but pressure threshold is the most commonly used and is the best supported in the literature right now, especially in rehabilitation. RMT incorporates inspiratory and expiratory muscle training. Some patients need both, some just one. Generally speaking, most people, especially when we're talking about people with medical conditions, are going to need just one, either inspiratory or expiratory muscle training at one time or as part of a therapy program. For a very simplified overview, inspiratory muscle training, or IMT, can be considered the dumbbell for the diaphragm, which is the primary muscle of inspiration. But IMT has other benefits too, like in ILO or inducible laryngeal obstruction. I've personally used IMT quite a bit to help to promote ventilation and trach liberation, so trying to get people off of ventilators. And that, when we are successful, that is one of the best outcomes I can experience. And expiratory muscle training, conversely, has benefits for the expiratory muscles. Surprise, surprise. And EMT is gaining popularity in treating certain deficits, particularly in dysphagia and cough. It's gaining a lot of popularity in the speech pathology literature as well. A lot of clinicians are also using expiratory muscle training for respiratory drive, for voice and speech. So a lot of benefits for IMT and EMT, and you can see they target two different things.
Yeah, super interesting to think about. I like that you're, kind of setting us up to think really separately about inspiratory, expiratory. For new people who are just starting this, like I've kind of seen people just throw anything at people. And so we want to really be intentional with how we're setting it up and how we're thinking about that.
Yep, great point.
Okay, so given that RMT is a relatively newer intervention in our field, can you tell us where we're at with the current research? So just kind of like a high-level view, like what do we know? What do we not yet know?
Definitely. If you have been in healthcare for any period of time, you probably are familiar with the fact that research is never in agreement. 100% yes, absolutely do this. 100% no, absolutely don't. And the same is true with the literature for RMT. And I want to break this down a little bit more into different categories for expiratory and inspiratory muscle training, just for, like you said, a higher level view. Let's start with swallowing and EMT. Quite a few studies show the benefits of EMT in improving swallowing safety and cough function, for example, in people with head and neck cancer, even years and years and years after their radiotherapy. But systematic reviews tell us that it's not really possible to say right now with 100% certainty that EMT is beneficial in improving swallowing function. And part of that is the nature of systematic reviews and the studies that are available for the systematic review. Especially in speech pathology, we only have a small number of studies in general, and then studies that qualify for systematic review. And just generally speaking, there's a lot of variability in the studies. It could be the patient population they're studying, the outcomes they're studying, the modality that they're studying, how they interpret the data. So I just say that to reinforce that we're talking about a systematic review here. But on the upside, one systematic review, which I provided in the resources for the show, suggests that there's preliminary support for maintenance of swallowing function in neurodegenerative disease with expiratory muscle training. So as a medical SLP who works with people with neurodegenerative disease and people who, for example, continue to get aspiration pneumonia over and over and over again, knowing that there's the potential to maintain swallowing function even for a shorter period of time is very exciting.
Very exciting. Those are the clinical populations that you just want anything as a little shred or a breadcrumb of hope. So that does sound really hopeful.
Yes. Yeah. It is really promising. And I hope to see more supporting research on swallowing and expiratory muscle training. And now I want to talk to you a little bit about cough and expiratory muscle training. A lot of people have started to incorporate EMT for cough strengthening. I don't know if that's something you've seen, Sarah, but a lot of people, especially in speech, are starting to incorporate EMT for cough training.
Yeah, definitely. Just like more research being done on the cough protectiveness and how can that compensate for aspiration.
Yep, exactly. And it's interesting because there's been a lot of popularity of using EMT for cough training, whether it's people talking to me about it or things I see on social media. But recent research is telling us that EMT alone may not be beneficial in improving cough function, and that cough skill training is likely more beneficial. So you might see EMT plus cough skill training, and you might see cough skill training or CST used in isolation. But overall, the research is telling us that EMT alone is not probably going to cut it for improving cough function in our patients.
Okay.
Now, moving on to IMT, in speech pathology, at least, I feel like it doesn't get the appreciation it deserves, and I'm always trying to change that. And it's interesting because a lot of respiratory muscle training started with inspiratory only. And so there's a lot of popularity in, for example, physical therapy and other clinical uses and other non-clinical uses for inspiratory muscle training. So I'm always trying to encourage my SLP colleagues to look more at IMT in addition to EMT. There's actually a good amount of research that demonstrates the benefits of IMT, and that's including in the trach and vent population, trying to liberate them from the ventilator, as well as some exciting medical benefits like lowering blood pressure in people with hypertension, which is a really nice thing. And I'm not saying that speech pathologists should start inspiratory muscle training because somebody has hypertension. That is not something that is within our scope to treat, but it could be a nice added benefit to inspiratory muscle training for the right patient population. And I'm also excited to see research on the benefits of IMT in other areas like balance and even things like stress urinary incontinence. So there's some pelvic floor applications here as well. That is a very, very tiny, but I'm hoping growing body of research. And again, as an SLP, I'm obviously not going to be treating somebody for pelvic floor dysfunction. But it's really good to know that there's potential added benefit, and it helps us to be aware of when to make appropriate interdisciplinary referrals. So long story short, as far as what the literature is telling us, there's a lot we still don't know, and there's a lot of really exciting new things coming out, and I can't wait to see more research on more areas for all disciplines to see really what added benefits there are for RMT.
That is really exciting. I love to hear about all the research being done on this topic. It's cool to see the new ideas that different professions are having. And I think it's also important that we stay aware of that as speech pathologists so that we can continue to advocate for our role using this tool also.
Definitely. And no matter what discipline we're in, it can feel a little bit frustrating to see all this evolving research. And I understand that I get frustrated too sometimes, where one day the research says, yes, this is great. And the next day it says, maybe not, or not so much. But it's important that we understand that we're honest with ourselves and our patients about the current conclusions and limitations in available research.
Yeah. So today, I thought it would be meaningful to focus our clinical discussion about using RMT with clients who do have neurodegenerative diagnoses. This often presents kind of like a mental sticky spot when SLPs are making clinical decisions because we know that those with neurodegenerative diagnoses have a different trajectory than those who might be recovering from something like stroke or brain injury. So
Right.
are you up for having that conversation with me today?
Yes, let's do it.
Okay, awesome. So first of all, when we're thinking about the different neurodegenerative diagnoses, lots of different things pop in my mind. The different dementias, multiple sclerosis, Parkinson's disease, ALS, Huntington's disease. Is it the type of thing where we know what certain diagnoses we want to consider using RMT with, or is that not exactly how we want to think about it?
Yeah, a lot of this is actually going to depend on the functional impairment that we're treating in the individual in front of us. Of course, taking into account what their diagnosis is or what their other diagnoses are. But there's more nuance than we can get into a podcast, of course. So I'm going to share some generalities. Parkinson's disease is where I'm going to start. Most commonly, people are recommending and using expiratory muscle training. EMT addresses pharyngeal dysphagia, for example, airway protection and cough, as well as improving the actual function of swallowing. And EMT also can improve speech and vocal loudness by improving breath support for speech. It's pretty similar for the MS population as well, though for both of these groups, there are studies that also show the benefits of IMT. So again, there's some of that variability in literature. And this is one of those things where it can feel really frustrating because there's no, if the patient has this diagnosis, use this therapy. But this is just the reality of our current literature and studies in human beings.
Yep.
And the PTs and OTs who might be listening to this podcast will be happy to hear that IMT can potentially improve 6-minute walk distance and can reduce perceived dyspnea in people with Parkinson's disease. And again, going back to how important it is to think of beyond just our scope and the real interdisciplinary nature of rehabilitation, keep in mind that research has shown that walking can even enhance the benefits provided by expiratory muscle training. So we can see RMT improving some modalities and some modalities helping to boost the benefits we see from RMT. In the ALS population, it's very interesting. There are studies that show that IMT and EMT can be well tolerated. I don't know if this was your experience, Sarah, but I know I'm certainly not alone in this. But in grad school, I was taught that you do not exercise people with ALS, that it is compensate and support. And so this is something that's really exciting is we're starting to learn that there can be good tolerance of exercise as long as we're really conscientious and measured about it.
Yeah, I always think of like the words overwhelm and underwhelm, and we just want to find the whelm, right? It's just how we explain it to patients, but
yes, and that's one of my favorite movies. So lovely. Love it. So back to ALS, we again know that IMT and EMT can be well tolerated. And I know of at least one study that shows that an early course of IMT could potentially increase survival in this population. So just starting IMT a little bit earlier Even just, I think in that study, it was like a 4-month difference, helped to prolong their life, their survival by even a small period of time, which is really, really powerful.
Yeah.
And a recent study of combined inspiratory and expiratory muscle training, typically these are studied separately, especially in the ALS population. So this study looked at people completing both IMT and EMT, and being able to do both was well tolerated in this population. But here's again where the nuance is this is completing both IMT and EMT was done at lower settings of the devices. So with that, there was also not quite the same improvement in function as we might see if the person were doing one in isolation at a higher setting.
Yeah.
So it's also important to point out that while we're talking about these different populations, not everyone is a candidate. And of course, earlier is better. So if you have somebody who was diagnosed with a neurodegenerative disease, 15 years ago and has a significant impairment, they may not be able to tolerate the same amount of exercise. They may not get the same benefit as somebody who was referred early and started on any sort of exercise program early, including RMT. So we really need to have good understanding of all of this nuance, specifically to RMT, and especially for our populations who have neurodegenerative diseases. And another great example of where we need to understand the nuance is the trach and vent population with or without neurodegenerative disease.
Yeah, so something I want to just ask this really specifically because we kind of circled around this. So whenever just in our field, when we're talking about doing like dysphagia or motor-based treatments with a diagnosis, a neurodegenerative diagnosis that has impacted muscles, we have that discussion, right? Like, is it worth doing exercises, or does this actually just cause muscle fatigue that's going to make things worse? Kind of like you mentioned, that's how we used to think about ALS, and now we're thinking, okay, actually we can do a little bit. And so I'm feeling those same questions really popping up when we're thinking about RMT and making those individual decisions for clients with a neurodegenerative disease. So can you just give us your mental template or share a little bit more about how you think about this nuanced topic?
Sure. Yeah, like you said, it's not always a straightforward decision when we're deciding about exercising versus compensating in general, and the same is true with RMT. So first of all, I am going to engage the person and or their care partner or care team in shared goal setting and decision making. Some people are not interested in doing exercise. Some people don't want any sort of therapy. Some people want to do everything. And so if we have somebody who doesn't want to do exercise or any sort of compensations even, there's really no sense in doing some sort of program, including respiratory muscle training. Now, when I get a referral for somebody with a neurodegenerative disease, I'm going to be thinking about a couple of different questions or thoughts. How long ago were they diagnosed, and how long ago did their symptoms start? Sometimes there's a really big gap here where they had symptoms for years and years and years before they were diagnosed. So I don't like to go based on the term recently diagnosed alone. I also want to know how severe their symptoms are and how rapidly they're progressing. So if it's someone who's having severe and or rapidly progressing symptoms, I may err more on the side of compensation versus therapy. Again, keeping in mind that whatever their diagnosis is going to play into this as well. And then I also am going to ask what other therapies and home exercise programs they're participating in. If they're seeing physical therapy already before they get to me, how much time are they spending doing their home exercise program? How many appointments per week are they going to? How much do those things fatigue them? Because if we're adding another thing on top of something that already fatigues them, we're really going to have to help the patient weigh what is going to be the most important for them, and hopefully talk to the other therapist on board about how to optimize this patient's care. Because I'll tell you from personal experience, when I'm being asked to do multiple things by multiple therapists, and I fortunately do not have a neurodegenerative disease, but I am just a human, it's a lot. It's a lot to ask of people, and especially people with multiple appointments and multiple diagnoses. So in that case, I also am going to ask them how they're prioritizing their goals for speech, OT, and PT. Sometimes speech is not important to them, but physical therapy is. I see that you're smiling knowingly because I think every SLP has heard this. So in that case, what does adding RMT look like to this person? And then I'm also going to want to know how they're performing with their daily tasks like talking and eating. Are those things incredibly fatiguing? If so, and we're going to add an exercise, I'm going to ask them to monitor for any changes in fatigue or difficulty with daily tasks. And then from an exercise perspective, if we complete a thorough evaluation and select the appropriate device and set it to the appropriate load for someone, I would posit that we're more likely to be actually exercising their muscles compared to maybe telling them to do 10 effortful swallows when we don't know if that's an adequate amount of exercise for them. So this is a bit of a double-edged sword because RMT makes it a little bit easier to dose exercise, but maybe we also will see more fatigue with a true or measurable exercise. And you know what? No one says we have to give every exercise to the patient on day one. So we can start with one exercise, whether it's RMT or something else, see how they tolerate it, and add more or change out the exercises from there.
Yeah. Yeah, I like that attitude, right? It's just like, we're not really set it and forget it. I mean, we're working with a person and their diagnosis can be variable from the next person. And so you're really giving people permission to take all of that into account and dial up or dial down whatever is needed.
Exactly.
As you are going through the clinical decision and goal setting process with these clients, can you describe like some of the things that you'd choose to measure if you do include RMT in the treatment plan?
Yeah, I always use something functional and related to their impairment. Maybe for swallowing, it's going to be the penetration aspiration scale. For somebody with dysarthria or dysphonia, maybe it's going to be vocal loudness. If the person has dysphagia and aspirates, and I can repeat a modified barium swallow, for example, I might also look at cough effectiveness. So there are a lot of functional and impairment-related measures that I want to do regardless of RMT or other modalities. And of course, the person's reports are so important. Are they saying that it's taking me less effort to talk? My spouse can hear me without me having to feel exhausted from raising my vocal loudness. I don't have to think about it as much. I'm having less coughing and chest congestion when I'm eating. So those things are really, really important too, and not necessarily numerically measured, but I think really, really powerful. And I know that you feel the same way about
Definitely.
Yeah. But there are other things that we can easily measure with RMT. For example, their MIP and MEP, which are their maximal inspiratory and expiratory pressures that are essentially indirect measures of respiratory muscle strength. It's measured in centimeters of water, so it's like a pressure measure. And we can also use the training load of the device. So maybe we set the initial training load of the device at, I'm just going to make something up, 50 centimeters of water. And then over time, they get stronger. And so we increase the load of the device to 60, 70, 80, whatever centimeters of water. So that's another surrogate way of measuring their strength.
Yep. Awesome. Okay, so you've kind of gone through in the clinical process the heavy lifting with the clinical decision making for RMT. So how does that then actually play out in the speech therapy session?
You want to think about this as another tool in your toolbox. This is not necessarily something that's going to replace other exercises completely, but it's probably something that we're going to be incorporating along with other exercises and/or strategies. In outpatient, I like to have the patient go through all of the reps in sets in at least one session and make sure they tolerate it and make sure they're completing the therapy with really good form. So maybe the first session that we start with RMT, I have them do say 5 sets of 6 repetitions, make sure they're tolerating it, make sure they're pacing it really well, because some people are going to need more support in that than others, and make sure they're not overdoing it either, especially in people with fatiguing conditions and who are highly ambitious. They're just going to have a little bit higher of a risk of overdoing things because they want to get better. So that would probably be my first session, is making sure that they're doing that appropriately. And then the next time they come in, I might have them show me what they've been doing at home and make any sort of tweaks or adjustments that are necessary. And eventually my goal is not necessarily to have them do all of the repetitions in front of me, as long as they're being successful at home, so we can focus their therapy on other things that may be more pressing. And then about every week or so, I might reassess their MIP and MEP and adjust their device and make sure we're progressing accordingly. So that's the outpatient setting, where I might be lucky to see somebody once or twice a week. Versus in acute care, it looks a bit different, since in a lot of cases, but not all, it's less likely for my patients to be able to do RMT on their own. Some people aren't even strong enough to hold the device. And there's, of course, a lot going on in the hospital. So it might be a little bit more challenging to make this be like a regimented or more structured home exercise program. And I might actually be the one doing the exercises with them in a visit. Pretty unlikely for me to see a patient 5 times a week in acute care as well, but we're going to do what we can and try to train them and their care partner in how to use the device, and follow similar concepts of outpatient, trying to reassess their strength and adjust the device approximately every week or so based on how they're doing.
Awesome. I was just thinking, so I just actually haven't heard you talk about MIP and MEP before, and those sound like such fun words to say. Do you say MIP and MEP a million times a day?
Fortunately, not a million times a day, but
Okay.
when I'm teaching, I do, yeah.
I always, when I have read it, I've always said MIP and MEP. So I actually just love to hear, oh, we just say MIP and MEP. That's great.
I've heard it MIP and MEP, and because I'm just so accustomed to saying MIP and MEP, my ears always perk up. It's like hearing a different word, and then I have to go. It's like another language where you go, I've recognized that.
Yeah.
Why? So funny.
So, okay, this might be a silly question, but I'm just going to ask it because I bet other SLPs listening might be wondering too. Can you talk about the actual process and maybe like the annoyance of the process of how you physically actually get the RMT device that you want to the patient, if it gets covered by insurance? Just that whole thing feels like a barrier.
That is definitely not a silly question, and it is absolutely a barrier for a lot of people. And this is something I could talk to you about all day, but I will break it down a little bit since we don't have all day. And the truth is that this question or this barrier is so common that I spend a chunk of time on it in my courses and give people resources for starting a program and trying to get devices at your organization, because every organization is different. Every setting is different. And I've been there and done that. And I just want to say from experience, I know how stressful and sometimes defeating it can feel. And, not everybody is going to have the same program set up at your organization. But I think with a little bit of creativity and persistence, you have a pretty good chance at being successful. And there are a number of ways you can do this. One is that you can try having your organization purchase the device and just eat the cost like they do exercise bands and other therapy materials. Some organizations, that's possible throughout the continuum of care from outpatient to ICU. Some organizations might be more willing to do that in hospitalized patients or people in rehab, and ask the outpatients to purchase their own devices. So there are a lot of different ways that you can approach this, and it's really going to depend on your organization. Another thing you could do if you're in the inpatient setting is to do a supply charge. Hospitals often do supply charges for toothbrushes and tissues and socks and all of those things. So you can potentially set up the device as a supply charge for part of their hospitalization. And then for outpatients, if your organization is a DME, an approved DME supplier, you could always set it up that way. Some organizations might sell the devices through pharmacy, for example. And of course, it's also possible to ask the patient to get their own device. And I've found that to be more often the case in places like outpatient and home health, especially. But this definitely presents its own challenges, especially from my experience as an outpatient clinician, working with people with a variety of financial resources. I know that sometimes a $50 device is not an easy ask. Some people can't afford the gas and parking to go to their appointments. So I know that that is not always easy. And some insurances do cover some devices. And it's very device dependent because it all relates to Medicare codes and all sorts of stuff that is just not very fun to talk about. But it is reality.
Yeah.
Not all devices are covered. Not all devices that are covered are necessarily covered by all insurances. So I always refer people to ask the device company directly because things could change. They're going to be the most up to date on whether their device is covered and by which insurance agencies. So that is my recommendation there as well. But you can also get creative, like I said, and try to do something like go through your organization's charitable offerings if they have anything like that.
Yeah. Sounds like with just kind of can-do attitude and really understanding your place of work, there are solutions that can be found. So thank you. I've learned so much from this chat, and I wanted to go through just thinking about maximum impact. What would be your top 3 actionable takeaways for clinicians to put into practice?
Top 3. Okay. First would have to be always, always, always be conscientious about candidacy. And this kind of ties into that program development stuff too, is we're not going to hand a device to every patient who has breathing difficulty, right? We have to tie RMT into a functional impairment. For example, difficulty breathing alone doesn't necessarily equate to candidacy for RMT. We have to ask ourselves why they're having difficulty breathing and how it relates to some sort of functional impairment. For example, is an SLP, swallowing impairment. The second I would have to say would be that we need to understand every patient's medical history and functional impairment and tie that into the available research for selecting a device that's appropriate for them. Not all devices are equal, so we have to make sure that we're savvy consumers because our patients are also relying on us to be savvy consumers for them. And read marketing claims and read the cited research for any device that you're considering. And remember that pressure threshold devices are those that are currently the best supported in the literature. And finally, I would say we need to know the ins and outs of a thorough assessment and principles of strength training for therapy, because if we don't do the therapy appropriately, we run the risk of harming the patient with too much load or wasting therapy with not enough load and asking the patient to do too many things for too long of a period. So we really, really need to understand how to do this assessment, decide what device is going to be best for the patient, what to set that device to, and how to progress them through their therapy.
Fantastic. Wonderful advice and really nice encouragement to people who maybe there's a culture of just like, hey, we just kind of throw these devices out to everybody. Like, you are really encouraging us to like ask those next questions and know that, because like you said, our patients do need us to be the savvy consumer and really providing the education about the purpose behind what we're doing. So Can we talk the audience through a couple case scenarios, just hypothetical case scenarios, so we can hear how this might play out in the real world?
Sure. Let's say that I'm in outpatient and I have a new patient referral. It's somebody with a 5-year history of Parkinson's disease, and they don't have any other medical history. And when they come in, their chief complaint is that they have dyspnea with exercise. They don't have any other complaints. They just get tired and short-winded when they exercise. But their spouse says they have difficulty hearing the patient. And if you have worked with Parkinson's disease, this probably sounds kind of familiar to you. So dyspnea with exercise isn't something that I address as a speech pathologist, but that could potentially be appropriately addressed by another discipline like OT or PT. So I'm already thinking, okay, the patient's chief concern is dyspnea with exercise. I can't address that, but there's potential for benefit of what I'm doing to spread over to exercise tolerance. And I also want to make sure that I have an appropriate referral to other disciplines. And as far as the patient's spouse is concerned and their difficulty hearing the patient, reduced vocal volume is something that can be addressed. And it does represent a functional impairment that may be improved by expiratory muscle training based on what we know in the literature. Additionally, since people with Parkinson's disease are prone to dysphagia, I'm going to go ahead and complete an MBS or modified barium swallow study as well. And let's say that I complete that MBS and discover that they don't have a significant pharyngeal dysphagia at this point. So no known impairments, but we know that there's a risk for developing pharyngeal dysphagia. So in the candidacy checkbox for RMT, we have reduced vocal volume, which is likely best addressed with EMT. And we also know that the research says that maybe EMT can help to prevent decline of swallowing function in neurodegenerative disease. So once I've decided that, yes, this person is a candidate, I'm going to complete MIP and MEP testing. And given that they have a history of Parkinson's, I'm going to start them with a training load of 75% of their MEP, which is a really important strength training principle, but it also helps me to select an appropriate device that incorporates their load and a range to grow into. So again, not set it and forget it, gives me an opportunity to increase the load when we are hopefully making progress in therapy. And again, following the principles of strength training, I am then going to set a program of 5 sets of 6 repetitions once a day and ask them to complete that 5 times a week. And let's say over time, this patient does a really great job completing their home exercise program, and we see gains in their strength and in their vocal loudness. So we're going to reassess their strength and increase the load on the trainer in order to continue to make gains. So you can see here how I have considered my patient's medical history and their functional impairments in selecting a modality, in this case, expiratory muscle training over inspiratory muscle training. And I incorporated that into my decision-making after a really thorough assessment, and am going to be incorporating principles of strength training into their therapy plan in order to maximize their functional gains.
Bravo. Thank you so much. That was really clear to follow. And I really like to see how there's like multiple points of clinical decision-making that we need to be intentional about.
Definitely.
Thank you so much. You are such a wonderful teacher on this topic. And I thought maybe to wrap things up, did you want to share any words of wisdom or inspiration with our audience?
Yeah, definitely. And thank you for having me. RMT has the potential to provide valuable improvements in functional outcomes for a variety of people, including those with neurodegenerative diseases, as we talked about today. And as clinicians, we have the power and responsibility to ensure that we understand the therapy and make sound recommendations based on the evidence and our training and based on the individual in front of us. We have to remember that we are responsible for making decisions beyond just marketing claims or clinical hearsay, or because there's this really cool device in the therapy closet that we have access to. And as I said earlier in the show, there's still a lot we don't know about RMT, and that can be frustrating. But again, we really have to be honest with ourselves and our patients about conclusions and limitations in the research that's currently available to us. So I encourage my fellow clinicians to complete a comprehensive training that teaches about a variety of devices and methods so that you can really understand all of the ins and outs of this. And I really want to make sure that my fellow clinicians are also staying up to date on research because, as we've talked about many times, it's always evolving. And just keep in mind that investing in deeply understanding skilled and evidence-based RMT isn't as daunting as you might fear. It's a pretty low investment of time and resources, but that investment is going to give you the power to improve so many people's lives.
Yeah, just imagine if it's your loved one. That's what I always think about. Thank you so much for sharing your knowledge, your passion with us today, your encouragement. And thanks, Brooke, for your clinical takeaways related to respiratory muscle training with neurodegenerative diagnoses.
Thank you for having me. It was great to talk to you.
Thank you for tuning in to this episode of SpeechScope by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. SpeechScope also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com.